we've changed panels. On the next panel, Jenny Patterson, who's our Director of Health Policy and Life Accident and Health Market Conduct, is going to moderate a discussion on strategies for managing covered populations and addressing drug costs. When this panel is done, at about 12:10, we'll take comments and questions for either panel, or any questions you may have, as a matter of fact. Jenny?
Great, thank you very much, Commissioner, and hopefully this is, yeah, I think can people hear me? I think they can. Yes. Good. So as Commissioner said, this second panel focuses really on market strategies for managing covered populations and cost, and especially drug costs. And for this panel, we've got the issuers who are really focused primarily in the group market. So I think it'll be interesting to follow up on some of the findings that Gorman presented about what we're seeing in the group market. So our distinguished panelists are Mark Butler from Cigna.
Morning. He's
the market president for Cigna. And then we also have Brian Wells, who is the president of Tufts Health Freedom Plan. Again, I think our time, 45 minutes, will go by very, very quickly. So I'll try to keep the discussion focused. I do want to make sure that we have time for questions at the end. So the suggestion is, if you have a question as we're talking, write it down and hold it up even during the discussion, so I can get a sense of how many questions there are out there. And I will do my best to leave some time at the end so that we can get to some of those questions. And Don will go around and collect them. So we hope to get to some of those questions. So let me start with Mark, and really focusing in on some of the presentation from the slides. We're very interested in what markets your organization has been focusing on and why. And specifically, as the slide showed, Cigna has really focused on the self-insured market. So maybe you could talk a little bit about what has driven that choice.
Sure. Good morning, everybody. First of all, I'd like to thank the department for having us in this morning, and thank you to the previous panel speakers. I've thought this was very interesting up to this point. Just a couple comments, and maybe just to level set our perspective as we make comments around this. But as most of you know, Cigna is a global company. We have about 40,000 employees. We're in the 50 states, and we're in 30 countries. So as we really think about, the types of insurers, self-insured plans, we think about the types of employers that we have centered in on. We have largely been a multi-state and local self-insured writer. And as you saw from some of the statistics up there this morning, our dominant market share in the state here is with self-funded employers. So we do market products in the fully insured space. There's very good competitive plans here, as we saw with both Anthem and Harvard, but we do sell fully insured products, but as we saw again this morning, not as significant of a share. But the self-funded market is really part of our lineage. If you understand what Cigna is and really why employers buy us, we're one of the few companies, really the only company, that wholly owns every piece of the healthcare dollar. So what that really means is, when we think about a medical plan, we own our own pharmacy benefit manager. We own our own behavioral health company. We own our own dental company. We own our own life insurance and disability company. And we own our own international company. So when we look at the strike zone of the employers that choose Cigna, they're generally those employers that are looking for bundled product services, because we believe and have demonstrated that the interactions between having all of those products and really having one view of those employers that are in those multiple products drives better health outcomes. The second reason that they choose us is they're generally looking to get more transparency around their claim cost data, which is generally easiest through a self-insured plan. And the actions that they take out of that data are actually to begin to construct incentive plans, look at different plan designs, look at areas of opportunity when we think about chronic condition management, diabetes, heart, much more transparent through a self-insured plan. So it's been a very strong area of focus for us. The employers that work with us are generally looking to balance cost share, a lot of the things that we heard about today, construct plan designs, and they're generally looking for consistent clinical protocol and product protocol across multiple locations.
Great, thank you very much. And I do have some follow-up questions, but I want to give Brian a chance
Sure.
to introduce himself and talk a little bit about the market focus that you've had.
Well, thank you to everyone for having us this morning. It has been a very, very good hearing. Appreciate it. Mike Wilkie measured his age by the number of plan designs that he's seen. I measure by the fact that I began my career as a pharmacist, and at the time, pharmacy was 1% of the medical cost. So
Wow.
I think I'm older than Mike. Tufts Health Freedom Plan maybe is very much kind of the opposite of Cigna. Number one, we're only a couple years old. Number two, we have actually 10 employees here in New Hampshire. And number three, we were actually founded by 5 of the largest health systems here in New Hampshire. While we are statewide and we are have all 26 acute care hospitals, again, we were founded by 5 of the systems who are half owners of ours. And we are totally focused on New Hampshire. We're not global, we're not national, we're totally focused on New Hampshire. We are, in fact, in both the small group and the large group business. We are the insurance carrier for those 5 owner systems, so we certainly take care of large groups, and we obviously work with small. I have a tremendous amount of respect for the folks who spoke from the first panel for their willingness to be in the individual market. What I have said is that the only thing certain about that is the uncertainty. And being a newcomer, we're not prepared to take on that level of risk at this point in time. So we've not entered into the individual market, but we are in small group and large group and fully insured and self-funded.
Great. Thank you very much. And let me start with a couple follow-up questions for you,
Sure.
Brian. Actually, talking about the fact that you only recently have come into New Hampshire and that you're relatively new. Can you talk about how your New Hampshire operations might be different from your Massachusetts operations, and how do you see them evolving?
Sure. So the fact that we are owned by 5 health systems, really what had come around was that the natural relationship between providers and insurance companies is one of contention. And these health systems decided that they wanted to be working much, much more collaboratively with the insurance carrier. So they said, we need to start our own insurance company. They weighed whether they would do that, where they would literally build it from ground up, or whether they would find someone to partner with. And they ultimately made the wise decision not to try and take on all the fixed administrative costs of building something from the ground up, and they partnered with Tufts Health Plan out of Massachusetts. It is a very, very different model because we essentially have much of the medical care that the insurance companies have taken on has been taken over by these health systems. Just as an example, all of the health insurance carriers employ nurses who make outreach calls to the members to follow up on their disease state, to encourage them to receive good quality care. And unfortunately, the members only accept that call about half the time. They don't want to talk to their insurance company, and so they just don't accept that phone call. So what we're doing is we actually have nurses who are embedded in the physician's practices, and they make that phone call, and the patient 99% of the time does in fact accept that phone call. So it's a very, very different model than what has traditionally been out there.
Interesting. And then, Dr. Brewster talked a little bit about their Benevera approach. Is that similar, or are there differences?
I think it's similar. I think the key thing is that this is literally an ownership. So those health systems, they bear on 49% of the bottom line results of Tufts Health Freedom Plan. So they are actively engaged in that in a very, very close fashion.
Interesting. Thank you. So Mark, one of the questions I wanted to ask you, just looking specifically at New Hampshire as a national carrier, where do you see the areas of opportunity? And I mean, clearly you're focused primarily on the self-funded. To what extent do you think in New Hampshire the trends on group coverage are driven by governmental plans, and how does that affect your strategy around participation?
So maybe just a broader context. So if we look at some of the data that we looked at this morning, they're embedded in that data. There are a lot of good things happening. So if we look at generic drug costs, we look at brand drug costs, we tend to always rush to the plus 37% that's going on in the specialty area and saying, what are we going to do about that? So number one, I would ask us to pause a little bit and put in the context that the work that hospital systems are doing, employers are doing, and employees are doing. Those are really kind of the three principal stakeholders. There is some very good work going on, and I truly believe that we are really in a transformative stage of healthcare in general. So what does that mean? So opportunities. So there's opportunities at the employer level to build better plans, to better educate, to better engage. Okay, we talk about those things, but if you sat 10 employers down, they would say, we don't have the engagement. We have the tools, we don't have enough people use them. If you think about preventative screenings, if we line 10 people up, 4 out of 10 are having a preventative screening. There's 6 individuals out of 10 where there's an opportunity to have preventative screenings, despite the fact that benefits have changed. But when you look into that at the employer level, there's time off concerns, there's money concerns, there's education concerns on value, et cetera, et cetera. So when you look at where we are and you look at the opportunities, number one, we have to continue to create win-win situations for the employer, the hospital and physician systems, and then as a payer, health services company, we need to be the facilitator that brings those people together. When we do bring them together, what you find out is that the disconnections that exist down at the employee level, Brian talked about this just a minute ago, the conversation between the employee and the physician, it isn't where you need it to be or you want it to be. And when you bring those folks together and we begin to talk about it, you'll hear the physician's offices say, we didn't know you were incenting those behaviors. Okay, we didn't understand from your employees you were doing this. So there's individual accountability. We heard this in the first group that needs to take place. There's education that needs to take place, and there's a continued enhanced collaboration that has to take place that creates wins for everybody in the systems. We can't have winners and losers anymore as we think about the traditional healthcare discussion.
I mean, it's very interesting as you think about as a group carrier, whether it's self-funded or fully insured, there inherently have to be some frictions between what the employer is looking for, what the member is looking for, and how you create those incentives. So I think, how do you think that employers are interested in plans? I mean, the education aspect of the members, like how do you address that? I mean, is that something employers are really interested in? Is having a component that educates the members?
Yes. So first of all, I would just again maybe start with, there are some employers doing really, really good work. Really good work. Again, we hear about trends and we hear about there's some employers that are doing really good work. We had the discussion in the first panel of, do we need legislation around plan designs? I would argue no. I think what we probably need to do is look more closely at some of the employers that are really doing good work. So to define good work, when you look at our overall book of business, and again, I have responsibility for all of New England, which of course New Hampshire component, but the movement to high deductible or consumer-based plans is significant. When that happens, it creates additional complexities that we talked about earlier. But the key here is that if you're going to go into a high deductible plan, it has to be constructed the right way. You heard Lisa talk about, the average deductible is $3,000, okay? So if you're going to have a successful high deductible plan, you have to think about your employee population, and you want people going into that plans from all risk stratifications. You want young and healthy, you want the moderately healthy, and you want those that are chronically ill. If the plan is constructed right in terms of how the deductibles, co-insurance, the incentive alignment to do the right things in the plan, then you will track, balance, risk. Those employers that have moved to that and have constructed it right and are building the appropriate incentives are the folks that are driving, very substantially decreased trends, and they're creating the engagement. Our role in that is to help educate. It's to help people understand what the incentives are and to really do that. And we have a whole piece of my organization that is dedicated strictly to that.
No, thank you. And I think Brian might want to weigh in on this one also.
Yeah, there's a difference between large employers and small employers. Unfortunately, the large employers tend to be focusing on wellness and productivity and preventive care. They're looking at things on a long term. And unfortunately, small employers have to look things on the short term. What's it cost me today? And so that's a natural difference. We obviously treat the populations exactly the same. Our mission is to improve the health of the population we serve. And so we will go out and make outreach to those people. For example, we have a program now engaging people in colonoscopies to make sure they're getting them, so that we will incur that claim. But as has been pointed out, when you capture an illness earlier, it is in fact a higher quality of care and it's less expensive. So we're taking that approach with all of our population.
Interesting. And one thing I wanted to ask both of you is, we saw the higher utilization trends that, Gorman talked about that. What do you think might be driving that?
You want to go first this time, right?
I think that it's largely around the pharmaceutical side of things, as we saw. That clearly is a big driver of this. And I think there are a couple of things that are happening there. There's a lack of transparency in the cost for pharmaceuticals that needs to be taken care of. The pharmaceutical companies are issuing coupons for their medications, and that essentially eliminates anything that might have been transparency and drives things up. So we need to tackle that in some fashion. I think it was also maybe referenced the point of there being advertising for pharmaceuticals is clearly a key part of that and stuff. And so those things are driving up, where you were seeing the greatest degree of increase on the medication side.
Do you have any thoughts? I mean, and specifically, this was the slide that showed, over the prior years, prior to the data they were looking at for this presentation, it was kind of the case mix was driving the trend, but now utilization has gone back up. And
right.
Do you have any thoughts on what's contributing to that?
Well, yeah, I think it's a little bit of the age-old issue in the industry, right? As you sort of reduce costs, okay, and then you have to watch out that if you reduce the cost of a particular service, that you don't find increased utilization at a lower cost, okay? Now, what collaboratives are designed to do, okay? So if we think of, again, Cigna, we have 4 collaboratives here. We were actually a pioneer of the first collaborative with Dartmouth-Hitchcock back in 2009. So one of the first collaboratives we had nationally. We have 200 nationally. But if you look inside a collaborative, back to the win-win, is the collaboratives are really designed to look at those very trends, okay? We look at the cost equation, and then we're actually going to go in and look at the util. So we heard an example, I think back in the original presentation and even the second panel about emergency room visits, okay? Way overutilized. We've done a very good job as an industry reducing the utilization, and we had to give them an answer. So it isn't just don't go to the emergency room, it's stop, think, pause. Do I need to go there? Or should I go to a minute clinic? Should I go to an urgent care facility? And generally, when I have an audience of folks, I would say, raise your hand if you'd like to go to the emergency room. Generally, everybody says no because it's a 4-hour minimum and the average cost is about $1,100. So one of the pieces that we're working on is as we look at the overall cost management, whether it's pharmacies or it's just general services in general, you also very quickly got to go over and you got to look at the utilization component. The way you do that is you bring the physicians, the health services companies together, and you begin to look at the data and find out where there's opportunity, given the reduced cost, that we still both subscribe to putting the right care and the right setting at the right amount of utilization. Those are really kind of the 3 things that you have to look at.
Great, thank you. I'm going to want to move on to asking about some of the articles that we had distributed, because I thought those were really interesting. Just one quick question for you, Brian, as a new entrant in New Hampshire, though, just from a financial perspective, moving into a new market, did things go as you expected? Were there any surprises coming into the new market?
Fortunately, it has gone actually as well or better than we have expected. I think that one of the questions that is out there is the idea of crossing state lines. And that's not something we've done. If we were just moving into if Tufts was just moving into New Hampshire on its own, it probably would have had a hard time getting competitive prices from the providers with no membership to start, and obviously being founded by these 5 large systems and engaging in coverage for their own employees. We were able to get competitive prices, and they would introduce us to other providers throughout the state, so we got competitive premiums there as well. So that was clearly, we were very, very successful in that regard. Our utilization has been as good or better than what we had hoped, and our medical expenses are as good or better than we've hoped, and our membership has grown better.
So really, having it be a border state was an advantage for you in coming in?
Absolutely, because we have full access to all of Massachusetts and Rhode Island as a part of the Tufts Health Plan network, being,
right.
Again, partnered together with ours here in New Hampshire.
Yeah.
Yep.
Oh, that's great. Thank you. So there was an article in the Wall Street Journal in August that describes kind of a broad reluctance to pay more for the latest and greatest version of insulin, even among patient advocacy groups. And so the consensus seems to be, we've gotten it good enough, we don't need to make it better, we don't need to pay more to make it better. What do you think this means for, not only drugs, but other healthcare services that might be an improvement, but not be worth the additional cost? And is there anything that you can do to facilitate kind of better cost-benefit analyses? So let Mark take that one first.
Sure,
if that's okay.
that question's chock full of nuts, right?
Yeah, it is.
It's a big question, but let's try to break it down. Just to reset everybody, so the Wall Street Journal article essentially was the point of view of pharmaceutical companies that had developed an insulin solution, and then they began to develop something that they thought was a substantially better solution than that drug. And typically what we see, I won't say in all cases, but typically what we see is we see innovation in the drug space. It generally comes with an increased, or let's just say at a cost. Okay? So the question really to be debated is if a particular drug does its job, however we want to define that, okay, by success rates, is a new drug that incrementally does that better at potentially a substantially higher cost worth it. Okay? So what's interesting is when you look at the article is the marketplace began to suggest it was not worth it. So where it puts the drug companies from their perspective in peril is that when we put $1 billion into research and development to improve something more substantially, but the market all of a sudden doesn't want to buy it, what do we do about that? Okay, they're just sort of the complexities of the equation. So we're going to continue to see those drugs come on the market for broader conditions. We're going to see those drugs continue to come on the market for more specialized medical conditions, and most in general come at a very hefty cost. So what do we do about that? So from a drug perspective, as I mentioned earlier, we own our own pharmacy benefit manager. So we have our own clinicians that look at that. There's a few things that you do. Number one, we have a 6-month hold that we put on new drugs that come in. And what that's really designed to do is to let us evaluate clinical effectiveness, and we're not going to put anything on our drug formulary that's not deemed to be clinically effective. But it also gives us time to work with the drug companies and look at that actual cost of that drug. Okay, so that's number one. Number two, we have inflation protectors that exist on some of these drugs. It's not terribly different than a lot of the other pharmacy benefit managers, but there are protocols in place today that look at that. Number three, any drug coming onto a formulary today has to have clinically based evidence that it's effective. Now we're moving into the cost equation. So one of the ways you get cost equations is you begin to differentiate or negotiate different types of contracts with drug companies. We heard the term earlier, value-based contracts. What's the value of this drug? What's the cost of it? You essentially begin to put risk in those contract negotiations, which is very different than the past. So I'll pause there and let Brian.
No, and I definitely want to let Brian. And Brian, were you at our annual hearing last year?
Yes.
Because I facilitated a panel where we had ICER, and we were really looking at this process of how do you do a real evaluation of the effectiveness kind of in the cost context. So I think this is really challenging, but I'm really interested in your perspective on it.
Well, you've hit it on the head. It really is challenging. Obviously, I think Mark really summed it up extremely well. And we have the traditional programs of looking at things from a formulary perspective for their effectiveness as best we can. But I guess what I would say is actually we're moving into a different transition, and I would bring back that word transparency. because it used to be the insurance company who made those nasty decisions about whether a drug was covered on the formulary or not covered on the formulary. Society is now starting to look at the holistic cost of that, and it becomes more of a societal evaluation than just the bad insurance company and thing. And I think that's a direction we need to continue to move.
Interesting. And that relates back, I mean, I think there's a question of, is this just drugs or is it other medical services? And there was this other article which on the Da Vinci robotic assisted surgery. And I thought that article was really interesting in terms of how do you look at the effectiveness and the benefits, because it sounded like for certain procedures there was a very high added costs and it didn't seem like it was worth it, but then for certain other circumstances it might actually really be cost effective. So is there any leverage in terms of working on how those trials get conducted so they give you the information that you need to understand when it is cost effective and when it isn't?
I think we're dependent upon the information from those trials, but I don't think we really have an influence relative to them. Again, we're kind of secondary to that stuff, unfortunately.
Do you have any thoughts on that?
Yeah, I'd make a general comment. It's more of a broader context, but when we think about robotics and we think about new technique, so there's a fact. If you have a millennial-aged child today, they will work for 3 companies in their lifetime that do not exist today. Okay, so just think about that a second. So when you think about healthcare and you think about robotics and you think about technology and where does that fit, okay, it's a very big balance between where are we right now, because we tend to look at now and maybe we look at next year. But if you look at 10 years and you look at the disruption that technology is going to cause in virtually everything that we do, we have to find a balance of the research, the trials, but we still have to bring that back to being clinically based and effective. Okay, because we do tend to be, let's run to it, this works, I've got to have it, but there's a cost associated with it, or we may find over the long haul that it's not actually clinically effective. So in a broader context, we're going to have to continue, I think, to recognize that because of what technology will do in our society, but we have to still come back to the clinical standards of care that need to exist. They're there for a reason, and they're going to be important as we go forward.
Brian, I think that really interesting point, and I'm just wondering, as a kind of a provider-based organization, do you have additional opportunities to look over time at effectiveness under particular circumstances? Is that something that
one of the things that we do is we bring the chief medical officers of these systems together, and so we have a collaborative discussion with them. And so again, it's not just the insurance company looking at it from the outside, but it's them actually bringing in the direct experience from their practices, from their systems and things, so we get that perspective as well.
Yep, that's great. I want to make sure we have time for questions from the audience if there are any. I do have a few additional questions if there aren't any. But Don, do we have any questions?
I have one, but I want to verbally add to what I wrote. Sorry. You answered.
So if you could, I mean, I think we
Sure.
will have the opportunity for public comment as well. So we want to make sure that we're collecting the audience questions. So I don't know.
To be fair, I thought I would bring up the other 3 panelists,
Yep.
and
That's a good
questions
idea.
could be asked to any of the 5 that sat on the panels.
I have a lot more questions for the first panel than I do the second panel.
Okay. So
Maybe you have more time.
And we
So,
have you can take a little more time if you want.
I mean, so maybe we should just take a little bit more time with this panel, and then maybe at noon bring back
Sure.
the other panel so that they can
Great.
have their questions.
That sounds good.
If that sounds good. I think one of the other questions that I had was kind of talking about your preferences for using prior authorization, utilization review, and case managers, as opposed to actually shifting financial risk to provider organizations. And kind of where do you fall on that spectrum? What do you think is the more effective way and appropriate way to handle that?
So I'll start with that. So we have a mix of that because the systems, as I said before, literally have ultimate financial responsibility. They are 49% owners of our health plan, and that goes to our bottom line. So it's not just a matter of a small risk share or up or down type of relationship. The other thing is we do look at things like prior authorization, and a perfect example of that is relative to physical therapy, which has historically required prior authorization. But we know that some 90% of people who have low back pain, if they have 6 weeks of physical therapy, can avoid surgery, don't need to have an MRI, so that saves them the cost and the risks associated with those procedures. And so we essentially simplified our process, and if the physician, this was again based on the input from those chief medical officers that I said before we bring together. And so we simplified it such that if the physician feels it's necessary, we absolutely approve it. We don't question that. We don't challenge that. So it's not really going through a prior authorization. It's up to them to be able to do it. So that's an example of the type of relationship we have.
Yep. Oh, that's great. And Mark, any thoughts on that question?
Yeah, I think Brian made a very good points, and actually I'd say the broader panel made very good points. So I think if the audience listens, I would feel very good about how the carriers are trying to work with some consistency. We all have variations with the different delivery systems, but I think very similar to what Brian said, we have prior authorization. So when we look at specialty injectables as an example, we put every specialty injectable through prior authorization. Why do we do that? Number one, because they're costly. Number two, we want to make sure that we are having the right medical outcome given that injectable that's being used, okay? And we have care coordinators and we have case managers that actually work through that. So that's number one, particularly when we look at the cost that it's driving inside of the system. The second piece, and Brian alluded to this earlier, is very similar to the model he mentioned. We work with embedded care coordinators in the hospital systems. We have care managers that work with them. That can be on chronic condition situations, diabetes, heart, those types of areas. But again, it's the movement towards healthcare delivered locally, okay, rather than through 1-800, the insurance company. Okay, generally I always again ask the question at 8 o'clock at night when you see the 800 number that says Cigna come in.
Right.
Is anybody looking to dive for the phone anymore? No, the answer, you'd rather have your physician calling you or a care coordinator call you. So I think the industry's done a good job of moving that forward. We do the same thing, very similar to what Brian said, is as you bring physicians together, you look for opportunities. The reality is in the delivery systems is they do some things really, really well. They need to be acknowledged for that. Over on the payer side, we do some things really, really well. So where the win is that how do you put those two pieces together and figure out how do we take the best of what both of us do and then actually deliver a better outcome for the individual.
Well, it's interesting because you have very different models for that, but really kind of similar philosophies, I think, in some ways.
Correct.
So the last question that I had is really looking at what the public's expectations are for health insurance companies. So I think it's kind of linked to what we've been talking about. Are there public expectations that are at odds with your business model, and if so, how do you address that?
I think our historical model has been at odds. People have looked at us as the bad guys. Those of us who started in this industry years and years ago, again, as pharmacists, those who have been involved in it have recognized that really we, the insurance companies, have gotten into improving the quality of the care. That has been our focus. It's not folks like Mark or myself who make decisions as to whether someone can or cannot have a procedure. It's a physician that makes that. And we do that on a peer-to-peer basis with the physicians who's requesting it. So we've not been as negative as people have seen us. But again, we're trying to hand that back even more to their physicians. That really, ultimately, if the physicians order the right tests in the right place, then there's no need for any external activity to take place. So I guess my vision of success in the future would be that we can diminish even further what we are doing from the external insurance side of things and having it back in the hands of the local providers.
Good, thank you.
Yeah, I never like to think we're at odds, okay? I view it, at least for Cigna, as two different components. We have economic value that we have to drive when we think about the employers that we represent, and we think about it in terms of the partnerships we have with the hospitals and physicians, okay? We have an economic responsibility. That's our role. But we also have, and this is changing very quickly, a broader social value. So think about, you know, when I get up every morning, I think, what's our economic value in the ecosystem here, but what's our social value in the ecosystem? So I'm going to use an example just to ground that point. We partner with an organization called Shatterproof. Shatterproof is an organization that is trying to raise awareness and remove the stigma that's associated with opioid addiction. And I will tell you a true story from last Saturday. So we did our first New England-based event in Franklin Park in Boston. We had 2,000 runners come out to raise awareness of that. And if we're going to be successful at that, again, socially, we brought the governor, we brought the police commissioner, we brought fire, we brought health service companies, we brought 3 hospital systems to that. So when we think about the opioid epidemic, and I know you folks here in New Hampshire, we've got it here, we've got it everywhere in New England. I grew up in a small town in Vermont. I go back there, that is not the town I grew up in anymore, largely driven by opioid in Bennington, Vermont. So while we were at that event, I'll end the story, I had one couple that came up after I spoke, and they hugged me and they thanked me because they had lost their son to opioid addiction, and we had helped them get through that, Cigna. I felt great about that. I was very appreciative of that. 5 minutes after that, I had a lady come up to me and started telling me that insurance companies are the evil empire. Okay, we don't cover things, we don't do things. So nobody was right or wrong in that, but the emotion that surrounds that opens up the broader piece of the social value that we all have to accept. We're not just really doing things on behalf of a client anymore. We have to be doing things on behalf of a community, because the opioid epidemic, because it's very front and center to all of us here right now, is not only affecting employers, it's affecting our our communities, where we live, where we work. So we have to assume that responsibility. We have to bring that down to the local level. That's part of my charge to do that.
No, that's great. Thank you. And thanks to both of you. I think what we'll do now is just bring up the other panel members, and then we can have some of the audience questions and have everybody address them.